All right, so the type of information that falls under this umbrella, safety is big. Deals with safety, obviously. Part of it is safety, the other part is infection control. So the thing is, safety is from preconception until death. Big area, right? Big area. So being from preconception until death, there we go. Okay, we're talking information like while the woman is pregnant, we tell her, don't go in the sauna, don't take over-the-counter medication, check with your OBG to make sure everything you're taking is prescribed. While they're in utero, we teach them about the cat litter for the toxoplasmosis. We when the child is born, we teach them about SID, sudden infant death syndrome. When the child is crawling, we tell them to childproof the home. When the toddler's walking, we tell them childproof the home and put everything, up high, lock it up, put prongs on the outlets. When they're a preschooler, their helmets and knee pads and elbow pads, like it goes on and on. The elderly, we teach them if they use a crutch or cane or walker to be careful with their assistive devices. So we really are talking from preconception until death. And some of this falls under other categories that we will cover again. So there'll be some repetition in certain areas, okay? Which is great. We like repetition. But with like accident, error, injury prevention, that area, there's a very small percent where it pertains to us, healthcare providers, right? Where we need to check clients' allergies. We need to make sure they're not allergic to food, latex. Some of you are allergic to penicillin. Some of you are allergic to peanuts, right? So those are like very common allergies. Also, remember when we did test taking strategies, we talked about biographical data. That's another component that brings its lovely little head, where depending on the client's age, the developmental stage, mental status, we take all of that into consideration when it comes to safety and safety measures. If they're visually impaired, right? That's a safety component. So sometimes you'll get a description in your question, you have to pick up on keywords, right? So these are some of the stuff we're going to talk about. Even some of our governing bodies put regulations on us. Very small percent of this pertains to us healthcare providers, okay? A nice chunk of it is really for the client, unless you become a client. I asked the earlier class, how often are you a client, right? Okay, so those are the type of things you're gonna be looking forward to. So here's a sample question of what's to come, okay? So in which way does a nurse play a key role in error prevention? What would be our job? So I want you to chime with me. Earlier, it did take a little bit of energy to get the other group to chime in with me. I'm not sure why. So I do want you to chime with me. As we're starting, I'm making sure, the other stuff are up so I can transition to that so that we can mimic the morning folks. So don't worry. So throw me some answers and I can see your answers here on that screen, because if I have to exit out of this one back and forth, it's going to take a little bit too much time. So I can see, your answers on this side. So chime with me, and there's a 30-second lag or delay. So don't worry if I wait for you for a few seconds. That's just the way it is. So identify incorrect dosage or potential interaction of ordered medication. Is that one way? Never. Now, that keyword never is an issue, right? That's an absolute. We already talked about those. But what I want you to see also, and I'm going to mention this again, how we building on. So you can't forget the stuff that we did day one. So never tells me, okay, something is wrong with that. That's an absolute. Is that an exception to the rule? Never questioning a physician's order. Yeah, we do question them. If it's not, what we know to be correct, or the book we open our drug guide, it tells us something different. Yeah, we're going to question it. Notify OSHA. Okay, you're jumping some chains, right? Remember we talked about chain of command. You're jumping some chains here. So informing the client of the Bill of Rights. Okay, so no, the best thing here, the best way you can play a key role in error prevention is identifying incorrect dosage and potential interaction. Okay, so those are some of the things that are coming up that we're going to talk about. Let me see some of your answers. Let me switch over here. Awesome. All right, ergonomic principles. So what is that? There are NCLEX questions on ergonomic principles. So ergonomic principle is a scientific discipline that addresses the human being and the environment. Us healthcare provider, there are a few things we need to know concerning ergonomic principles. So, but a lot of this does deal with the client. I'm going to show you the piece that deals with us. But for the most part, their client, our patient, this principle is a discipline that addresses them and their environment. Okay, how are they balancing? Can they transfer? Are they using assistive devices? Are they using a crutch, a cane, a walker? You know, when they're moving something, are they moving, you know, that object properly? Same thing with us. When we're moving a client or an object, are we doing that properly? Are we lifting, you know, with our thigh muscle versus our back muscle? So all these little things make a difference. It's going to prevent us from injuring ourselves or the client from injuring themselves, right? It's going to optimize our ability. Now, the young and the old. All right, so even all this safety stuff we're about to talk about, really, it's the young and the old. Very few, small percent of it pertains to us as healthcare providers. So we're talking safety and infection control, our topic today, right? So safety, we need to talk about fire safety. We need to talk about electrical safety. We need to talk about chemical safety, radiation safety. So you see these pictures here. Those are all the topics that we're going to talk about today. Now, question for you. Which one here, or there's a couple here that affects us healthcare providers? Which ones? So I have 4 pictures here for you. Which of the 4 pictures affects us healthcare providers? Talk to me. Which 2 pictures? Yeah, the shop containers. One more. And the biohazard. Yes. Okay, perfect. So now let's talk about home fire safety. So it is our job to go to the client's home and do an assessment. So some silly little stuff I see students forget here. Again, nothing heavy, but for example, you always want to make sure like there's at least 2 exits out of the home, right? That the fire alarm is working, the batteries are replaced every 6 months, that there's a fire extinguisher in the home. Let me make this bigger so you can see some of this, right? So it's silly little things like that you need to make sure, you know, are happening. So when you get a chance, this picture is great because it has, you know, all of the stuff that we would love for you to have in your home. So when you go to a home and you're doing this assessment, you want to make sure you know the stuff that are here are present, especially with the whole battery thing and the fire alarm. That's extremely important, okay? So there are a few little mnemonics. Like, you know, these are so important that most facilities will give you a badge with these little mnemonics on the back, right? So the little mnemonics help you to remember, you know, when Joint Commission comes, what you should say, because, you know, they make us nervous. So there's a facility response plan, okay, called PRC. P stands for protect client, right, because we're client-centered. R stands for reporting the fire, and C stands for containing the fire. That is the acronym for the facility response. So we're talking about the whole facility. The job of the entire hospital is to protect clients, report fire, contain fire, right? So now let's talk about, there's a fire on a specific unit, okay? And you, the nurse, work on that unit. As a matter of fact, the fire, where the fire is in one of your client's rooms, okay? So there's a little mnemonic, RACE. Now we teach you, RACE, it's on the back of your badge, right? Number one, we're patient-centered, we're client-centered. It's all about the client. You're going to rescue or remove the client. That's the R. A stands for activate the fire alarm. C stands for containing the fire. And E stands for extinguishing the fire. I'm going to give you a quick story so you'll see how all of this ties together, and I could see why, you know, questions come concerning this. And I've had to use RACE in the past. So a while back, this was before the pandemic, I used to use candles. You see, I say used to. I don't anymore. I used to use candles because I love, you know, when the whole house smells good and things like that. So we keep one in the bathroom, and I have my routine. I don't know if y'all have routine. I got my routine. So one of my routine is to light the candles in the morning. So I lit the candle in the bathroom and I went about my business. And then I hear this horrible sound, and I'm like, what the heck is that sound? I go outside, nothing. I go to the back door, nothing. I go to the front door, and I'm like, this is the fire alarm, you know? And I'm like, why is the fire alarm going off? So I walk around the house. When I opened the bathroom door, the bathroom was on fire. I'm not talking about a little fire in the candle jar. The bathroom was on fire. So I was like, oh my God. And I'm thinking, where is the fire extinguisher? So thank God I had just recently seen it. It was under one of the cabinets in the kitchen. So I grabbed it, and I literally had to think about my mnemonics. I didn't rescue it because everybody was still asleep. It was like 6 o'clock in the morning. But I did have to remember this little mnemonic, okay? Because I had to extinguish this fire. So literally, I'm thinking, what's the mnemonic again? I teach it all the time. I remember it. So students have told me they've had to remember this on the NCLEX, and I've had to remember this in real life. So pull, aim, squeeze, and you sweep, right? Side to side. And the whole fire thing was my daughter's fault. She put all these little toilet paper in the wax, and that's what caused the madness. So ever since, my son's looking at me really weird right now. Ever since, we kind of, it's so funny, not long after that, I got exposed to Scentsy, the ones that the light bulb melts the wax. So we've been using that ever since. As a matter of fact, she ended up building a business that I'm trying to help her with the Scentsy, since we almost burned down the house. But anyway, NCLEX, please remember RACE and PASS, okay? And again, they're in the back of your badges. Any questions with those two? We're gonna go into another topic. All right, our next topic is poison. Poison control. So this is a very important one. Whenever you get these questions where the client calls you, the child has instilled some poisonous substance, or whatever it is, there may be a risk for poisoning, our priority, our first goal is to remove as much of the poison out of the client as possible, right? But these are those questions where, you know, it might be a phone call, so you need to tell the client, you know, bring the container, find out the weight of the individual, the whole, let's go over the why, right? The whole reason for bringing the container is because here in the United States, if you grab any household item, you will see there's a caution section, right? That tells you how to handle poisoning. Like seriously, it's mandated. So you go under your cabinet, I go under my cabinet right here. Every household object has to have that here in this country. So that's why we want you to bring it in, because they're supposed to be able to tell us right on the bottle if there's an overdose or poisoning, How do we handle that? So that's number one. Number two, the reason you want to know the weight, of the individual and all of that is so you could prepare the antidote if there's an antidote, right? If you watch that show that I keep telling you to watch, Untold Stories of the ER, there's several cases like that. Even, with snake poisoning, trying to get the antidote depending on the type of snake that it is. So stuff like that. So priority, first thing is to remove as much of the poison out of the client as possible. So how do we do that? And by the way, this is a section that must be handled in this specific order. So whenever material are like that, I point that out to you because this is one of those questions, put in the right order, your nursing intervention. So step one, the best thing, the first thing, the initial thing, the priority thing is to remove the poison. How do we do that? Okay, so gastric lavage is the best. Vomiting is not. Why, you ask? Thank you. Vomiting is not because you would induce vomiting depending on the substance itself. For example, you would not want to induce vomiting with substances that are alkaline or acidic, especially acidic, right? Because what's in your stomach, okay, your gastrointestinal is acidic. So that substance went down burning your esophagus because it is acidic, not mixed with even more acidic content. And then you're bringing it back up, you're gonna burn the esophagus again. So be careful, caution, do not induce vomiting if poison contains alkaline or acid agents, such as lye, household cleaners, oven cleaners, you get the point. So now, first thing, best thing, initial thing is gastric lavage, okay? So we'd rather stick a tube down your stomach and bring the poison up that way, okay? Then we want to neutralize whatever's left because you're not gonna be able to bring everything back up, right? So the way we neutralize what's left is via activated charcoal. Activated charcoal is gonna bind to whatever is left, okay, to deactivate it, to make it useless at that point, okay? And at the same time, we're gonna do some supportive care. We're gonna put on some IV fluid, right? We're gonna manage any signs and symptoms you have. Especially if you were late stage where the client is going to shock, they're having seizures, aspiration. So we're going to manage those symptoms, right? Put them on seizure precautions, suction them, put them sideways. So all these little things we're gonna do. And if there's an antidote after all of that, one more time, after all of that, by all of that, I mean the gastric lavage, the charcoal, the IV fluid, after all of that, then you give your antidote. That is an NCLEX question. Imagine, and it makes sense, everyone, because my job is to get you to the critical thinking level, right? If you give the antidote first, wouldn't you wash it out with the gastric lavage? If you give the antidote first, wouldn't you deactivate it with the charcoal? That makes sense. So you would never do that first or second. No, it has to be after the gastric lavage, after the charcoal, okay? Any questions with that? And if you get that question, you're doing well, okay? It requires a bit of critical thinking. And to me, it just makes sense. All right, so again, before I got into these topics, I told you the young and the old, okay? The little ones, you need to childproof the home. Once they're crawling, you need to childproof the home because they're at highest risk of this happening to them, okay? Poison looks like candy to them. They don't know, they'll eat the rat poison. Everything goes in their mouth. So not only does it need to be up high, it needs to be locked up. Now, this is a silly answer to a question, but if you think about it, it makes so much sense. The number one way to prevent poisoning is supervision. That makes sense. If you're watching the child, you're not going to watch them eat that rat poison, right? That makes sense. If you're watching the child, you're not going to watch them drink that Clorox. So supervision is the #1 way to prevent poisoning, and that makes sense. So in your questions, as you're reading the answers, if you don't see an adult supervising this child, then that's the one you want to intervene. That's how they phrase these questions, right? Which scenario would you intervene? The one where there's a child and no adult. That one makes sense, okay? Older adults get poisoned for different reasons. They mix alcohol with medication and herbs, right? One of the common medications that gets mixed with alcohol are your anti-anxiolytics, okay? I don't know why folks do that, but folks do that. They take medication in the dark. They don't know what they're taking. They share medication. You know, Viagra is shared a lot, which shouldn't be. They take expired medication, okay? So don't forget, tell them to take the substance with them to the emergency room. All right, any questions on that topic? Because we're gonna move on to another topic. Fall is another important one. Talk to me. Everybody's good with safety, okay? We just did fire. You memorizing these little mnemonics. We did poison control, the young and the old. Now we're going to do fall. Any questions so far? Let me know. Just say, nope, I'm good. I get it. Not heavy. Good stuff. Bad stuff. Oh my. Let me reconnect and refresh. Just to make sure. All right, everybody's good? Okay, awesome. Thank you. Thank you, Ms. Gladys. All right, fall prevention. Now, we need to assess who is at risk for fall. Again, you and I in the middle, okay? This is, again, another young and old, especially old. So we want to assess the risk factors. Now, there are different types of risk. Some risks are what we call intrinsic factors, those risk factors, and some risk factors we call extrinsic. What's the difference between the two? Intrinsic factors are like your age and your health. And extrinsic, X, outside, deals with the environment, whether they use assisted devices or not, whether they have the right foot gear. Some factors are modifiable. You can change them, the client can change them. Some are non-modifiable. You can't do anything about it. How many of you can help or change the fact that you're aging? Nobody. That's a non-modifiable, right? Modifiable would be more like your health. We have some control over that, right? Keeping your weight down, exercising, stretching your joints, all of that is under your control. Okay. Now, you see that stuff in red? History of fall places patient at greatest risk for fall. That is so true. If you fell before, you are at highest risk of falling again. So you know there are questions in the end because we call them risk factor questions because that's all they're testing to see that you know the risk factors. So know who's at risk, right? The person that they'll give you a bunch of scenarios. They ask you who here is at highest risk to fall. Whoever fell before, that's it. Whoever fell before is at highest risk of falling again. Okay? A client with chronic, progressive, multiple sclerosis is learning to use a walker. What instruction will best ensure the client's safety? And I could easily turn this into a select all that apply, right? Right. We can, it's not right now, but we could easily turn this into a select all that apply. What instruction will best ensure the client's safety? So we're looking for good stuff here. Do you see how I went back to my STEM and I get myself heading in the right direction. So I go back to my stem. I'm like, what am I looking for here? I'm looking for good stuff, right? You have to do that. 1, place the walker directly in front of you and step into it as you move it forward. 2, when you move the walker, set the back leg down first, then step into it. 3, maintain a firm grip on the front bar as you step into the walker. 4, send me some answers while we read. 4, use a walker with wheels to help you move forward. Send me some answers. You're ensuring the client's safety. Number 3 says maintain a firm grip on the front bar. Is it the front bar or the side bar? Picture that. It says front bar. Is it front or side? So you see what's wrong with number 1? I'm sorry, with number 3? Number 3 says front bar. It's the side bars. Okay, so it was number 1, just to be on the safe side. Number 3, the problem was the front. It should be the side. So how do we prevent falls? Okay, so we want to do a history. We want to look at what medications they're on, what's their medical condition, what are they diagnosed with, do they have incontinence, is it happening at night, do they use any assistive devices? We want to do all of that, because if there's any risk of them falling, we want to be able to prevent it. And we prevent it by being in tune and abreast of information and being proactive and setting things in place. So if they have a history for fall, we're going to keep the bed low. We're going to put the lights on. We're going to have the grips. We're going to have the right socks, right? The non-skid stuff, right? Medical history. What are they diagnosed with that could put them at risk for fall? Are all their senses intact? Are their vision fine? Their hearing fine? Their sensation, is that all intact? What meds do they have that crosses the blood-brain barrier that could make them dizzy, cause orthostatic hypotension? Are they incontinent of urine or stool? Are they having nocturia, where they're getting up in the middle of the night frequently? Do they use a crutch, a cane, a walker? Like, what's going on? So all of that we want to assess. And then there's so much. I know I mentioned this stuff verbally, but there's so much you can do to prevent them from falling. Keep everything close by, because don't they reach over and fall, right? And then last measure, you always want to do a 1-to-1 sitter. Never tie up, drug up, lock up clients because of risk for fall. That's unethical. Don't pick that answer, because you're telling your test makers that you're unethical for you to just lock up, drug up, tie up somebody because they're at risk for fall. Okay, so 1-to-1 sitter. After you do all this other stuff we're talking about, the call lights, the low bed, locking the bed, night light, fitted shoe, all of that, then a 1-to-1 sitter, okay? So some age-specific risk factors, you can imagine it. The infants, they don't know any better. They'll just tumble down the stairs, right? Toddlers, preschoolers, depending on what they're doing, riding their tricycles, playing little sports. You know, the school ages are definitely playing sports. The adolescents, they're playing sports. They're learning how to drive. Okay, young adult, middle adult have some risk factors. The elderly have some risk factors. when we go over growth and development, we'll go over some of the normal aging factors that you will see puts people at risk. Okay, this is just an example of the full risk assessment. Okay, and you see here one of the things that is focused on is recent falls. Okay, they've never fell before in the last 3 months. They had 1 to 2 falls in the last 3 months, 3 or more falls. Like this client, I would be watching like a hawk. You fell 3 times or more in the last 3 months. What's going on? Right? Can you ambulate by yourself? Are you chair bound, bed bound? Like what's going on? Are you mentally together? Are you alert oriented? Are you disoriented? Can you see well? What is your vision like? Are you legally blind? Balance. Can you walk in a straight line? So these assessment tells us what we need to be ready for. Okay? There's several little mnemonics out there for you. Use the one that, you know, is best for you. You can make up your own too. All right, this topic is about us, healthcare providers. I told you there's not many questions about us, for us, with us, that deals with us. Let me make sure you can hear me on this end. And then you can see the PowerPoint, yes. Okay, so when we move clients, we need to make certain that we have proper body mechanics, okay? And this little mnemonic here or picture here really helps. So if you have other people to help you, that makes sense, right? 2 of us better than 1 of us. It's always good to widen your gait, okay? Open your legs, bend at the knees, not the back. You see so many nurses out there have the back brace and all of that's because they weren't moving these things and clients the proper way. Okay, tighten your stomach muscle, lift with your leg muscle, not your back muscle. It's always better to keep things close than away because then you sway, okay? So here's an example. Oops, no cheating. A client observes a nursing assistant bending over a bed as she helps an obese client sit up. The nurse discusses her observations with the nursing assistant to reinforce the need for proper body mechanics. So this is how they would phrase a question like that. And look how it's a select all that apply. So if you're not well in tuned with the proper body mechanics, you may not get this question correct. So this is just testing to see how well you know proper body mechanic. Which response indicate that the nursing assistant understands. So that keyword understands tells me I'm looking for good stuff. So you see how it's good to learn the material, learn how to test it, because I'm reinforcing some stuff that you need to make second nature. So I see here the word understand. So I tell myself I'm looking for good stuff. So start chiming with me, okay? I need to keep my back straight and lift with my thigh muscle. I need to keep my elbow bent and use my thigh muscle to bear the weight. I should bend at the knee, keep my back straight and pull the client up. I should stand at the client's side, grasp the draw sheet and pull the client up. I should ask the client to help as much as possible. Oh, I don't see any answers yet. Okay. So proper body mechanic. Why am I not seeing the answers yet? Is it me? Okay, can everybody chime with me? It's not a holiday, is it? Okay. Let me put my volume up, make sure you can hear me. Make sure it's not just me. Okay, some answers are coming. All right, just making sure. I guess it's just not a lot of you here right now, but that's okay. All right, so 1 and 5, and I see some of those answers. Yes. What's wrong with number 4? I should stand at the client's side, grasp the draw sheet, and pull the client up. Now imagine that with an obese client. So there's a possibility they might even roll over on you based on that visual learner if you do exactly what they're saying here. So yeah, 1 and 5 are the best ones here. I think 3 is also a couple of you. Let's go over 3. So 3 says I should bend at the knee, keep my back straight, and pull the client up. So with this one, you also want to get some assistance from the client as well. And again, that wouldn't even be possible with this obese client as well. Who else? 3, 1, 5, 5, 1, 5, 1, 5, 3, 5, 3, 5. Okay, just make sure. All right, let's go over a couple other topics that somewhat deal with us still, okay? Not so many, again, deal with us, but these are us. So with the biohazards, the sharp containers, we need to know, when it's a third full type of thing, and what companies are, in charge of that, who puts the security plan and safety together. We also have departments, that are handling these things. So that also brings us to infection control. I'm going to go over the definition of some of these companies with you in a moment. But we're getting into some infection control stuff, right? Because part of the sharp containers, the biohazards and all of that, that falls under infection control. Now, nobody goes to the hospital to catch an infection, y'all, right? Nobody. So putting on those PPEs are vital. Knowing about diseases and how they're caught, whether they're bacterial or viral or, fungal, whatever it is, those are the sections we're getting into. And I'm going to show you some documents that you're going to have to spend time with. You're going to have to print. Well, this may be some of your strong suits. So if you're already strong there, not a big deal. But if you're not strong there, you may have to print these things, work on them, and get them under your belt. So when teaching parents about fifth disease, erythema infectiosum, and its transmission, the nurse should provide which information? Fifth disease is transmitted by respiratory secretion. Fifth disease has an unknown transmission mode. Fifth disease is transmitted by respiratory secretion, stool, and urine. Fifth disease is transmitted by stool. So this is the type of information that's coming up. 1 and 5. So the answer for the last question was 1 and 5. Great question. So what we're doing here is what's coming up. So we're going to go over a lot of pathogens, and we're going to go over whether they're bacteria, whether they're viral. How do you catch them? How do you prevent from catching them? How do you prevent from spreading them? What are some of the treatments? So those are some of what we're going to talk about, because infection control, not only is it big, remember, every quarter you get pools of questions. So the quarters are January, February, March. Quarter 1. Quarter 2, April, May, June. Quarter 3, July, August, September. Quarter 4, October, November, December, right? So every 3 months is a new quarter, and every quarter are a pool of questions. So if you go take your test and you see a lot of infectious disease questions, it's not because they added them because of COVID. They haven't changed the tests pertaining to COVID at all. Okay, so don't think you're gonna get more infection control because of COVID. No. Now, when they revamp the test in 2021, probably, right? But for now, they cannot change your exam because of COVID. The exam changes when it's time for the exam to change, and it's not time. So, however, whether they're pulling more infectious disease questions, because actually they won't do that either because of the percent. Remember, each section weighs a different percent of questions. So as far as, you know, infectious disease, these questions were already on the board. So you're not going to get more infectious disease questions because of the situation we're in. But this is an example of what's coming. So you do need to know that fifth disease, go back, is spread via respiratory, right? There is a mode. It's not oral fecal, okay? It's respiratory, okay? And we're going to go over fifth disease so you'll know, but these are the type of questions coming up. And in addition to that, you also need to know how to roommate people, right? Based on what it is that they have, do they need a private room? Do they need a negative pressured room? Do they need a positive pressured room? How do we gear up when we go into the room? What PPEs do we put on, right? How do we put on PPEs? How do we take off PPEs? So there's quite a few things to know under this umbrella, and that's just how it is. And these are very important. All right, signs and symptoms. Yeah, the answer was number 1 for the last question. Signs and symptoms of infection. So infection happens when pathogens, bad guys, right? They're the bad guys, get into our bodies, a person, okay? A host, could be an animal. There's local infection and there's systemic infections. And we do need to know how the client presents based on the type of infection. So we're gonna go through that. And that is like the beginning. You know, we always start easy and then we get more complex. This is the easy part. So localized infection, local, that area, okay? That specific area is gonna be warm to touch. It's gonna be swollen, edema, it's gonna be red, some drainage, it's gonna, some itching maybe, pain, tenderness. It's localized, but it's in one area. It's not all over the body. Respiratory infection, respiratory, right? So you know there's gonna be some coughing, right? Some sore throat, some congestion, because we're talking respiratory, sputum production, chest pain, runny nose, rales, rhonchi, beautiful noisy stuff, maybe not beautiful, but noisy in the respiratory tract when you're listening with your stethoscope. Gastrointestinal, or for short, you'll hear us say GI. Okay, gastrointestinal, anorexia, vomiting, diarrhea, nausea, because it's a gastrointestinal tract infection. GU, genital urinary, because we're dealing with the urinary system. You're talking urgency. It's gonna burn when they urinate. They're gonna have some discharge, maybe foul smelling, frequency, pelvic pain, itching, because we're talking genital urinary. Now, generalized is very different from all that we've talked about. You see how those were pertaining to systems. Localize that area. Respiratory, the respiratory tract. Gastrointestinal, yeah, gastrourinary, GU. Generalize has hit the entire system, your bloodstream, whether it be via the lymphatic system, hemolytic, whatever. It's generalized, which is very dangerous, those type of infections, right? So they're not gonna wanna eat, right? Anorexia, malaise, fever. You knew that was gonna be a part of it because we're talking generalized, right? Weakness, muscle ache, right? Because it's generalized, okay? So let's continue. There are 4 ways that these pathogens or infections get into us, gets transmitted. It's gonna be either via contact, and under contact, there's direct and there's indirect contact. So let's go over those 2 before we go over the others. So contact, is it direct contact or is it indirect contact? So direct contact is, for example, the client has a wound and you have a cut. Your cut, your open cut, touches the client's wound. That's direct. Okay? Or somebody sneezes in your face. Nasty. But that's direct. I kind of just need you to get the point. Indirect is through an imminent object. Okay, so for example, you have a wound, you touch the table, somebody else has a wound, they come and touch that spot of the table where you had the wound, and you leave, like, let's say MRSA. Let's say, God forbid, one client has MRSA, methicillin-resistant Staphylococcus aureus. They touch the table, they touch the doorknob, right? And nobody cleans it. And somebody with a wound, an open area, again, comes and touches the table or the doorknob. So that would be an indirect contact. So some of those most popular pathogens, we list them here for you. Staphylococcus aureus, your sexually transmitted infections like gonorrhea, HIV, syphilis, chlamydia. Fecal-oral would be your hepatitis, Shigella. You eat it, you drink it, you go to the bathroom, use the bathroom and don't wash your hands type of thing. Droplets falls more under like the umbrella of the influenzas and the tuberculosis. We'll talk about those in a moment. So those are all contact. Another way is a vehicle. So sometimes these pathogens gets, to the client via even like drinking water that's not filtered, right? Or eating a burger that's not well done, your uncooked food, salmonella, blood, water. Airborne, we're talking about microbes that are really, 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 really small, like tuberculosis, where it's less than 5 micrometers. I need a picture of that in there one day. Vector would be like mosquitoes and fleas and ticks. Okay? So is it contact, vehicle, airborne, or vector? Okay, those are the 4 ways of transmission. How or the environment you catch it has a different terminology. So if you catch it in the community, they call that community acquired. You caught it in the community, makes sense. If you caught it in the hospital, it used to be called nosocomial. It's not called that anymore. It's now called healthcare acquired, which is better to me because it tells you healthcare acquired within the facility, a hospital, healthcare, any healthcare facility. And if it's not, it's in the community. That makes sense to me. I don't know who came up with that whole nosocomial term. Here's an example question on the bottom right. So you'll see what I'm talking about. How would you okay, well, how would they phrase a question like that? Here you go. Which client is at highest risk for developing hospital-acquired infections? So you need to make this make sense. Which infection here do you catch while hospitalized? A client with a laceration to the left hand, a client who's taking prednisone, a client with an indwelling urinary catheter, a client with Crohn's disease. Talk to me, everyone. Which condition here would you catch while hospitalized? Because the question is asking who's at highest risk of developing a hospital-acquired infection. Laceration to the left hand? Yes, the urinary. Thank you. Thank you for my one awake student. I appreciate you. Indwelling urinary catheter. Yes, because the others are not hospitalized. Okay? So that's how they would phrase that. Next, precaution types. So now that you know some of the ways we could catch these infections. There's another umbrella under precaution types that we need to go over. Who, in other words, do we use what for, right? So there is percussion type standard, direct or indirect contact, droplets, and we have a couple more we're gonna go over, airborne and neutropenic. So the first one, standardized, is the one we use for everyone. Everyone has everything until I know exactly what you've got. Okay, that's standard. Direct or indirect? Direct or indirect? Remember we talked about direct contact versus indirect contact? So here's some examples of your pathogens again. But I want to point out something about C. difficile, Clostridium difficile. There's something special about C. diff, and we have to pull that information out because it's an NCLEX question. Now, throughout facilities and hospitals, we have the alcohol foams for you, right? Quick. C. diff, you must wash your hands. That doesn't work on C. diff. You need soap and water. You need to literally wash your hands and go through the whole process and then to get C. diff off of you. All right, so that's an NCLEX question. Don't get it wrong. Okay. Droplets. So with the droplets, anytime a condition causes sneezing and coughing, they're gonna be on droplet precaution, right? Ugh, nobody wants that. So it's in the air, but it doesn't linger in the air like your micro, right? Like tuberculosis does. With tuberculosis, like they cough and sneeze, and the microbes linger in the air and they stay there. That's a problem. But with your droplet, they cough and they sneeze and it drops to surface. And that's why we want you with your gown, because you're touching and rubbing stuff on you, right? We don't want that stuff on you. So that would be your droplet. So examples would be Streptococcus bacteria, adenovirus, rhinovirus, Neisseria meningitis, pertussis, right? Lots of coughing with that one. Influenza is droplet. A couple more precautions. Airborne. So chickenpox, measles, TB, all on your NCLEX under airborne. Because what happens, these pathogens, again, they linger and they linger and they linger in the air. So you want to make sure you wear what we call your N95 or particulate filtered mask, right? It has two names. You do need to know both. And these are the clients, the airborne precaution clients, they go in the negative pressured room. Why? Because with the negative pressured room, we filter the air and vent it outside, like 6 to 12 times per minute. It's just vent out. So that's the negative pressure. The other reason is because these clients with rubiola, with varicella, with mycobacterium tuberculosis, those clients, they're considered to be contagious, right? Or I want to say dirty, but not in a disrespectful way, because we're going to talk about roommating clients, and you never want to roommate a clean, immunosuppressed client. We're going to talk about them in a moment, with a dirty, contagious client. So they're in the negative pressured room because we want to protect the public from them. We want to protect everybody else from them. They have something that we don't want everyone else catching, right? So negative pressured room for them, okay? Let's talk about the N95, the particulate filtered mask. Who wears that mask? Talk to me. Do we wear the mask or do the clients? Do our patients ever wear a N95? Now, I know now these days, everybody gets their hands on an N95 and they're going around with it, but we're gonna stick to NCLEX questions, right? Who wears the N95 in your NCLEX question? Does the client wear those? No. Why? Because we, the healthcare providers, we get fitted for those masks. You don't just slap an N95 on. Well, before COVID, you didn't just slap an N95 on, right? You had to be fitted for it. So I work infectious disease for many years, and I get fitted for my mask, right? Literally, I'm a medium. So I put my medium mask on and I put the hood on, or the nurse puts the hood on, and they spray several different contents in the hood and ask me, do I smell it? Do I taste anything? That's how you figure out what size mask is proper. So if, God forbid, the client does have to leave their room, which we try to prevent, right? But there are some diagnostic tests where the client can't go there, right? I'm sorry, the tech can't come to the client, so the client has to go there. There are some diagnostics tests like that, right? Like they need an MRI. We're not going to bring an MRI machine to their room. They're going to have to go. So they put a surgical mask on. Just make sure they have it on and they're not coughing and sneezing, but we wear the mask. We wear the N95. We wear the particulate filtered mask, okay? And don't forget, when we talk about tuberculosis, we'll go more in depth, because these are the clients where the infectious disease nurse from the community has to, you have to tell the CDC sends someone, and you follow them into the community, making sure they're taking the medications, all of that. But that's not this section. All right, neutropenic precaution. So now, with your airborne precaution, your dirty clients, right? They have fevers, they have contagious infections. But the opposite of that, the neutropenic client, those are your clean clients. They're immunosuppressed. Their blood, the white counts are low. That's your leukemia client, your chemo client, your low white count client. So your cytopenia clients, all of those clients, they're immunosuppressed. We want to protect them from the public, because if, God forbid, you let anybody into that client's room, which is the positive pressure room, by the way, you let anybody into that room and the client, let's say, catches a cold from them, because they're immunosuppressed, they can't fight it back, okay? So we're gonna recap. And then I'll go into these definitions and make sure, yes. Let's recap. So you have your standard, everybody. Direct versus indirect. We're going to talk about PPEs, what you put on, what you take off, and all of that in a moment. You have your droplet, you have your airborne, and your neutropenic, okay? Clients. Airborne, negative pressure. Neutropenic, positive pressure, okay? Can you make sure you don't have any questions? Okay, perfect. All right, so earlier I mentioned these folks to you, the CDC, OSHA, Joint Commission, and we've talked about Joint Commission before. Let's talk about CDC for a moment there. This is who really falls under this umbrella, and OSHA as well. So Center for Disease Control. So you know their job, and you've seen they've been all over the news since COVID. Their job is to collect data on communicable diseases. That is why some diseases were mandated by law to pick up the phone and let CDC know so that they could keep track of it, okay? The whole purpose is for future effective care, okay? How many clients, what area, where do we need to provide information, all of that, okay? OSHA, their job is to protect the health of us healthcare providers, okay? So the rules and standards and stuff they have with the shop containers and the biohazard bags and all of that is to protect us, okay? They've implemented the bloodborne pathogen standards that we follow, okay, to protect us healthcare providers from bloodborne pathogens like hepatitis B, hepatitis C, HIV, that's them, okay? And Joint Commission accredits facilities, okay? All right, we'll take a break after the PPE portion. So chain of command, not command, of infection. We did chain of command already. I'm so used to saying chain of command, but chain of infection. So what's the whole cycle of catching and recovering from an infection? There is a whole cycle, okay? So we have these causative agents, whether it be bacterial, fungal, viral, parasitic, but there's an agent, there's a pathogen, okay? The pathogen needs a reservoir, whether it be us, an animal, an inanimate object, which they don't survive without a host on those, which is great. So some pathogens need a body to survive. But what happens is some pathogens, until they get a body, they can survive a moment without a body. 6 weeks, I think, is a long time. And MRSA, Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, staph can last 6 weeks without a host. That's a long time, folks. Can you imagine how many people touch doorknob, in certain places within 6 weeks? A lot, okay? So portal of exit, how do they get out of their host or their area to go to the other? Blood, intestinal tract, when you have a bowel movement, when you coughing, sneezing, right? Or if you have a wound and opening, that's how they get out. Some of this could be airborne, contact, vector, a mosquito takes it from one person to another, right? Nasty. Portal of entry, how are they getting in? So I mentioned intestinal tract. Somebody goes to the bathroom, they don't wipe properly, they don't wash their hands, they make sandwiches. And daycare workers change diapers all day long, right? Yeah, not a good job. Respiratory tract, somebody breathes it in. Let me tell you a true story, and there's a couple NCLEX question in this story. I don't like to share stories unless they're NCLEX question related. So, and this is such a good example I shared with a lot of classes. I remember many, many years ago, I was working with my oldest son. He's now 17. That tells you how long ago that was. He was 3 years old, maybe 4. We were walking to the speech therapist. He had a speech impediment when he was growing up. He wouldn't pronounce like his L's and stuff. So I remember this like it was yesterday because it was just so disgusting. We were walking down the hallway. And as we were walking, we passed this lady who sneezed on us, literally right when we were about to pass her. Achoo! Ugh, gross. The next day, both Michael and I had a sore throat. We started getting sick. We caught the common cold, whatever was going on, from her during that season. But that is how the change started. So that's what we call, I'm going to come to this in a moment, that's what we call stages of infection. So the moment she sneezed on us, from the time we got our first sign and symptom was our incubation period. And then we go through another stage called prodromal, where we're coughing and sneezing and spreading our wealth, right? That's when we're most contagious and we need to stay away from other people. And then when we have such specific symptoms, we can be diagnosed. That's called our invasive phase. And then we go into a convalescent phase where we get better. So those are stages. So him and I are both young and healthy. We do not fall under what you would call a susceptible host. So a susceptible host are those clients who cannot fight it like my son and I did, right? If they already have other chronic illnesses, they're hypertensive, they're diabetics, there's a lot of visceral fat, right? If their immunity is already low, okay? Nutritionally deficit, chemo, radiation, surgery, whatever. So all of these put clients under the umbrella that we call susceptible. It's not easy for them to fight it back like other people would, okay? So that's your chain of infection. Recap: the pathogen, the reservoir, how it exits, the mode it transmits, how it enters, and who is susceptible, okay? And the chain continues. Here's an example. A client is placed in isolation. Client isolation techniques attempt to break the chain of infection by interfering with. So you put this client in isolation. Which part of the chain are you breaking or stopping? Is it the agent? Is it the susceptible host? Is it the transmission mode or the portal of entry? What in that cycle that I just explained to you that you're stopping when you put a client on isolation? Are you stopping the pathogen, susceptible host, the mode of how it transmits, or the portal of how it enters? Okay, some of you are still awake. Yes, it's the transmission mode. Awesome. So that's a way they phrase what I just explained to you. Okay, so you see how it's good to get questions right after, and we're going to get a lot of questions at the end, but it's good to get the questions right after because it kind of tells you, because a lot of time you're reading this, you're studying this, you're like, how do they phrase this? Like, how would this question be phrased? That's why it's important to do questions right after you learn the material. That is vital. And as a matter of fact, while you're studying, you want to ask yourself, how would they phrase this? I think that is something that helps me tremendously, and that is something that I've learned to now do naturally. It makes, I guess it's easy for people who are a little inquisitive. Don't just take an answer. I want to know why. You love me, why? Right? So it's good to ask that, because that helps you build the critical thinking. And it helps you, I think that's just a life thing too, not just the NCLEX thing. Somebody comes and they want to be your friend. Why? Do they come with good motives? Are they showing good motives? Does that make sense what they're telling you? So silly little thing, but bring that habit. It will help with not just NCLEX, it will help with life. Ask good questions, or at least ask questions. Okay, or ask why if you can't think of any question. Why? And you'll be surprised how many people just accept information and not know why. Okay, why are we heading in in the dark away from the light? Why are we heading toward that big old ravine? I don't want to fall in there. All right, so seriously though, hopefully you remember that from my stupid jokes. All right. This little table right there, you need to spend a moment with, and I'm going to make it a little bit more complicated and in-depth and show you some stuff that you do need to spend some time with, okay? I'm just a messenger. So you do need to know the different types of infection, okay? These are simple questions. So for example, you see on the left here, we have some central nervous system infections. We have some childhood preventable infections. We have some gastrointestinal, some acute bacterial, viral gastrointestinal, some hemolytic infections, some respiratory, sexually transmitted urinary tract infections. You do need to know what infection fall under what system, right? For example, I give you a question and I tell you the client has pyelonephritis, right? You need to know this is through the urinary tract. That's how it's going to get to the kidneys. Not going to get there, other ways. I tell you the client has been exposed to botulism. That's gastrointestinal. They somehow ingested that. They ate that or drank that dirty whatever it was. Your blood stuff, your hemolymphatic stuff, that's mononucleosis, nicknamed mono. Cytomegalovirus, toxoplasmosis, which we'll talk about when we do OB. Those are all hemolymphatic. I think you're familiar with the STIs, gonorrhea, chlamydia, syphilis, AIDS, genital warts. Those are the sexually transmitted infections. The childhood ones I think you're familiar with as well, measles, mumps, rubella, pertussis, varicella, diphtheria, right? Encephalitis, that's central nervous system, meningitis. So you've got to spend a moment on this tab. This one is from Learning Extension. They did a very good job with that, so I'm borrowing it. You're good with the stages, okay? There's incubation from the moment of introduction to your first symptom is stage 1. From your first symptom until you're contagious, you're spreading it. Stage 3 is invasive, where you get diagnosed. Stage 4 is convalescent. So the isolation period needs to happen even before prodromal, okay? Because some pathogens, you're very much at risk before any signs and symptoms show up, which is terrible. All right, this is the section where we're gonna get into PPEs, okay? All right, so if I say aseptic technique, I'm referring to the practice in general that helps reduce risk of infection. But under aseptic technique, am I talking medical asepsis or surgical asepsis, right? Umbrella, under the umbrella, 2 subcategories or umbrellas. Medical asepsis is also known as clean technique. So we are reducing the number of pathogens, but there are still pathogens with medical asepsis. Surgical asepsis is a sterile technique. There are no pathogens, none, zero, nada, zip, rien, right? I don't know who speaks what language, so I think I covered a good 4 or 5 different languages here, right? So surgical asepsis is autoclaved, it is sterile, it is free from all microbes. So we're going to talk about when do we use what? Okay, when do we use medical asepsis? When do we use surgical asepsis? But first, you need to know their meaning. A couple more vocabulary words that falls under aseptic technique. Antiseptic are chemical agents that we use on our skin, like alcohol, betadine, right? We can use those on the skin, and we can use them on mucous membrane. They remove or kill microorganisms, but they're fine for the skin, okay? We don't use those on instruments or, well, for NCLEX we don't, because I know I use alcohol on my countertops. All right, but let's stick to the book. So in real life, that's different. I use alcohol to wipe stuff off all the time. I did that way before COVID. Like I told you, I did these classes live in my tutoring center, and I had a habit. After every class, I throw alcohol on all the desks and chairs. This was way before COVID, because I have a little thing. But the book says, I am not going by the book on this one, but we gotta go by the book for your exam, right? So the book says antiseptics are for skin and mucous membrane, whatever. Disinfectants are for objects. So by disinfectants, we're talking Pine Sol, Clorox, whatever household stuff you use. Like I even use some stuff from Cincy, because you know they use all natural stuff, organic stuff, and all that. But those are for tables and chairs and doorknobs and stuff like that. Okay. All right. So you're good. Medical versus surgical, antiseptic, disinfectant. They're all different. Okay. So now a nurse will use surgical asepsis for which procedure? This is what we're getting into. This is the type of questions that you have to be very, very, very good at. So surgical, not medical, surgical, not medical, surgical. So when you read these questions, if you don't process that one little word, how are you going to answer that? Because I promise you there's some medical answers there, right? Yes. When they do that, they're going to put both. Okay? So the nurse will use surgical asepsis for hand washing, nasogastric tube irrigation, IV catheter insertion, or colostomy irrigation. Talk to me, everyone. A nurse will use surgical asepsis for which procedure? Not medical asepsis, surgical asepsis. Remember, medical has some pathogens. Surgical is clean as ever gonna get. It is sterile, it is autoclaved, there's no pathogen. What procedure here would you choose to not introduce any type of pathogen to the client? Is it with hand washing, nasogastric tube insertion, which goes into the stomach, IV catheter insertion, which goes into the bloodstream, or colostomy irrigation? You're taking out poop. So which one here would we use surgical? Start sending me some answers. Ooh. Anybody else? Yes, it's the bloodstream. Anything that's going to be touching bloodstream needs to be sterile. So let's talk about that, medical versus surgical. So, you know, we use standard for everybody. All patients, universal precaution is the other word. Your personal protective equipment, we're going to talk about hand washing. That's all standard. Everybody gets that. Doesn't matter who, what, where, when. We went over these, the transmission base. So now let's go over, I'm going to come back to this in a moment, I promise. We talked about the N95. Hold on, let's go to, actually, I have to deviate for a moment. I'm going to deviate to a couple of other documents you need to come into play with, but let me cover this and then I'll deviate to rigs and NCLEX and show you some things with medical versus surgical. All right, so PPEs. Whenever, what's that other little mnemonic? Let me go back to this. I have a little one, clean versus dirty. I don't see it. Did I remove it? Why would I remove it? Hold on. I might have. Okay, you know that little mnemonic that shows you clean versus dirty? I must have been updating it with a new one, but I'll show it to you. It's on Rigs and NCLEX. Okay, so when we're talking about surgical versus medical, so let's do medical first. So you would use medical asepsis for anything that's not going to touch bloodstream. It's fine for colostomies. It's fine for the GI tract, especially because you have all that acidic stuff that's going to kill it. But whenever you're talking bloodstream, you have to go sterile. You don't want any type of pathogen touching the bloodstream because then you're going to risk sepsis, okay? And that's what we're trying to avoid. So with your, as you saw here, with your, where is it? Too far. Hold on. Hand washing, this one. With your standard, you see we're using that for all client and it involves PPEs. So when you put on your PPEs, you have to go by what the CDC says as far as personal protective equipment. Why? Because NCLEX uses the standards of the CDC. You see on the bottom right hand, I've got the CDC logo in here. So this comes directly from the CDC. So that's something that I do that's extremely important. Be careful when you're taking reviews from folks and they're using stuff that's not what's going to be used on your NCLEX, okay? So that's very important to me. I always want to get information from the horse's mouth, right? That means that the person, I didn't, you know, you didn't hear it from a cousin, third removed, from the best friend of the brother, and no, go to the source. So your NCLEX uses CDC, I use CDC, right? Because why would I want information? So be careful with this one because you can Google YouTube videos that are showing you the wrong way to do this. So you need to go by the same source that the NCLEX is using, and NCLEX is using CDC. So we're talking standard precaution, medical asepsis, which part of medical asepsis are the PPEs for everybody, right? Everybody has everything until I know what you've got. So here's step one, or one part of it, is putting on your personal protective equipment. So you need to make a little mnemonic. I know there's a bunch out there, but I would advise you to make one that pertains to you. Okay, and if you already know one, you want to share it with the rest of the class, please do so. But your gown is first, then your mask or respirator, then your goggles or face shield, then your gloves when you're putting on. And you know the gown needs to fully cover your front, fully all the way to your neck, right? Because again, we just talked about droplets that you don't want on you if you pick up the client's linen or if you lean on their table. Okay, all the way to the end of your wrist. Okay, and wrap around to the back. Your mask or respirator has to be securely tied, okay, at the middle of your head and neck, too, if you have this type, right? And then you want to do a fit check respirator. You want to, right? Or you could do the hood if you have the ability to do that. The goggles and face shield over the face and eyes adjust to fit, because if it's not fitting, it's going to fall off. What's the point of that? And then your gloves need to cover your wrist, right? No area needs to be out or can be out or should be out. Don't touch your face afterwards. Limit surface touched. Change glove whenever they get soiled. And then you know you wash your hands after. So that's the putting on. Let's talk about taking off, removing off, donning off. So which is the dirtiest part? The gloves. So they come off first. And that makes sense, right? They're the dirtiest, they're the most contaminated. So they come off first because what's underneath is not dirty. Then after you take your gloves, then you take off your goggles or face shield. Then you take off your gown. Then you take off the mask or respirator. And you see how they're touching the cleanest part of all of that. Then you wash your hands again. These CDC charts have the best and most information that I've seen. That is a really great document that was put out many years ago by the CDC. And we're going to go over that. It's over here, so I'm going to close it from here. We're going to go over that because they did such a wonderful job with breaking down the childhood diseases. And they went over, so as we go through this document, you'll see they went over what it is, how it's spread, okay, which as we talk about how it's spread, we'll talk about how to gear on with your PPEs. When the person is most contagious with some of these pathogens, it's important to know that because that also tells you when to isolate them, right? And of course, how to prevent the spread of. So not all of these pathogens you need to have under your belt, but a lot of them, yeah, you do get questioned on these. So you do have to spend a moment here, okay? I know this one could be a little time consuming, but you have to do it. So how are illness and infestation spread? So most of these are through direct and indirect that I just talked to you about, right? Especially with children, they're coughing, they're sneezing, they don't know how to properly, cough in their shirts, and they just don't. So you have one infected person or child who coughs and sneezes without using a tissue or without using it inside their arm or inside their shirts, and here you go, droplets everywhere. Okay, whether it be viral or bacterial, it's not even relevant. They're not using, that precaution. So they may have that virus or bacteria in their hands. They go touch everything. And that's why, you know, the moment school starts, your kids come home with something. Yeah. My kids just recently started gymnastics. So when they went back to gymnastics, the little one started, like, I think it was just a cold. And then I believe my daughter ended up with it, then my son, then the other son, then it just spread because, yep, they're coughing and sneezing and spreading the word. So the moment I see something coming, I usually start to build their immune system. I'm big with the cod liver. So that's just the way this thing is. And then we can't see it, right? It would be nice if they come in all purple, lime green, right? Like in these pictures here where we can say, okay, you have a virus, bacteria in your hands, go wash your hands. No, so the frequent hand washing is the best way to prevent that. You know, that's a level 1 question. And you also know that people who work with children in daycare, there's that NCLEX question, right? Who's most at risk? Yeah, the one with 50 little diapers to change. So us healthcare providers as well, especially if you work in the pediatric setting and they're not potty trained. So here, several of these infections are gastrointestinal, or sometimes you'll see the words oral fecal. Okay, stomach, bowel, oral fecal, the mouth, the anus. The bacterial virus often found in contaminated, dirty food and water, and they're transmitted that way when people eat uncooked, right? Food and meat and stuff like that. So that's why it's important to cook everything, to make it well done, right? To filter your water, okay? There is direct contact with the stool, feces of an infected person. The caregivers, again, with the diapers. So please don't miss that question. There is indirect contact with infected stool. So those are the people who use the bathroom, don't do hand washing and cook for you, or somehow they get it on something you're gonna eat, okay? It's on their hands. That's why hand washing is the number 1. Hand washing is the number 1. And it makes so much sense. Here's another type of pathogen that you need to be aware of. Take a break. Head lice. So head lice is not really okay. So head lice is not gonna cause illness. It's an infestation. Okay, not an infection. So it's an infestation. Head lice does not cause the illness. It infests that area, the scalp, but it doesn't cause the child to be sick. Ringworms, scabies, and pinworms can cause infections or illness, but not head lice. Okay, head lice, ringworms, scabies, and pinworm are spread by direct contact. You have to touch the person, right? Put your hand all in their hair and then put it in somebody else's hair, type of thing. People that are in close proximity with each other. That's why because they're not gonna jump, right? They don't do somersault to the other person. I say these funny things to help you remember this stuff. So yeah, so head lice, you need to be in close proximity. They sleep on the same bed. They share pillows and stuff like that. Comb, right? That makes sense. I comb my hair. I pass it to the other person. They comb their hair, and then the nits, the eggs, go from one head to the other. You're sharing hats, helmets, headphones. That's how you catch those. Okay. So you see how this little document is so important. A few more I want to point, and I'm going to go through a few of them where I got to pull and collect stuff out. This you can read on your own. This is some stuff I just said verbally, you know, teaching them how to cough properly and sneeze and everything. Even when you're cleaning, how to disinfect. So you see with the bleach, it's 1 to 100. 1 part bleach, 100 part water. So if you have 5 mLs of bleach, you need 500 mLs of water. That's how you dilute, right? 1 to 50, 1 part bleach, 50 part water. So you must dilute it. And like folks with immunosuppressed, they can dip their toothbrush in the diluted bleach to kill whatever's in there. Okay. So those are some little things you can read, stuff you already know. Cook your food, I mentioned it. The fresh stuff, make sure you're washing them thoroughly, like those who like fresh salads and stuff, because bacteria is on them. Okay. Hand washing, you can read, you know, you wash your hands before the client, after the client, before the next client. So before preparing food. So this is stuff, again, I don't want to read to you, but you do want to take a look at it, right? How to wash your hands and stuff. I'm going to get to sections that are super NCLEX related. Okay. They have lots of resources for you. All right. So here's where we start. And I don't ever want you to see a bacteria that you're not familiar with. You don't know whether it's, rather, I don't want you to see a pathogen you're not familiar with, whether it's bacterial, viral, fungal, you know, protozoa, you do need to know that stuff. So, Campylobacteriosis is a bacteria. The word is in there, makes it easier. This affects the GI. So the moment you hear me say that, you know there's going to be some nausea, some vomiting, some diarrhea, some cramping, right? Abdominal pain. Most likely in the summer, early fall is when children catch this one. Okay. There are several types of them that causes the illness, but not too big of a deal. Like it's not as common. So how do we prevent it? So well, rather let's go over how it's spread, right? And then we'll know how to prevent it. So hand washing, because it's oral fecal, eating raw and uncooked meat, cook your food, right? Especially uncooked chicken, right? So don't give children, I want to say the age is 12. Yeah, I believe the age is 12, where it's very dangerous for children to eat uncooked meat. What happened is some children, it travels to their heart and cause a lot of damage. Not this one in particular, but yeah, so cook the food. Okay. So again, the hand washing, so that tells you how to prevent from getting it. Okay. So very easy to prevent. All right, this one you need to be really, really familiar with, chicken pox, varicella, which you probably already are, but let me pull out some NCLEX stuff, right? So you know this one is viral, okay? So you're not gonna use antibiotics because it's viral. So signs and symptoms of chicken pox, the fever, okay? The rash, and don't forget with the rash, you want to keep that child isolated until all, not some, all of the scabs have dried up. First they have to burst, right? And they have to fall off, dry off. Everything has to, until then the child is contagious, okay? It usually appears on the body, face, and scalp, and then it spreads through the arms and legs, okay? It starts in small red flat spots that gets very itchy, you know that. And then what happens? The nails, we have to keep them short, right? Because they scratch here, then scratch here, then scratch here, then scratch, and then they just spread that beautiful, ugh. You know, I'm being sarcastic. They're very small red. After the blisters break, they open sores. They're gonna crust up. They're gonna dry up. They're gonna fall off. After that, then the child can be around other people. That goes for a good week and a half, right? And you know, later in life, those who have had chicken pox, for some people, not everybody, the virus can become active again later in life and cause what we call shingles. But what causes shingles to come back is your low immune system. So it is extremely important to keep your immune system intact, to stay with that nice high immunity. Because the moment you get stressed and your immune system dives down, then you end up with shingles. Okay, very painful. It's spread via direct contact, so isolate them. Okay, and with the blisters, so until those blisters fall up, crust up, dry off, you know, you're back to your old self. Stay away from other people. Don't contact other people. And it's part of the infected person's saliva, so no sharing. Here's NCLEX stuff again. No sharing of spoons, forks, utensils, plates, right? This is the child, you're washing their clothes in hot water away from everybody else's clothes. Yes, that's all NCLEX stuff, okay? A pregnant woman with chicken pox can pass it on to the baby during pregnancy. Keep that in mind, okay? breathing in air contaminated with virus when an infected person has cough or sneeze. So isolate them. They need to be in that negative pressured room by themselves. I know, but it is what it is. So recap, viral. Client is contagious well after the blisters must dry up, cross off, fall off. Don't share anything with anybody. Negative pressured room. Pregnant mother can give it to the baby. Saliva. The good thing is with chicken pox, it does not live on objects. So it needs a host, it needs a person. Thank God. From 2 days before the spots appear, you're contagious with chicken pox. Isn't that horrible? So you don't have any signs and symptoms yet that's visible to the eyes, and yet you're contagious. That's the problem. So the child goes to school for 2 days before, any signs and symptoms come. Those 2 days, they're spreading it to all the other friends they come in contact with. From 2 days before the spot appears and until all blisters have crusted over, they're contagious. Terrible. Same thing with fifth disease, which we're going to go over. They're contagious. They have it. Nobody knows. Separate them. Separate them. That's why, I worked infectious disease for many years. Whenever a client comes on our unit with chickenpox, the pregnant nurse can't take that client. Okay? And I think I've shared with you all before, I worked with a nurse who most of the time she was pregnant on an infectious disease unit. No sense. And we vaccinate. All right. The cold sore you're very familiar with, but just to recap and bring some NCLEX stuff to the forefront. With the cold sore, we're talking herpes simplex virus 1. Okay, herpes simplex type 1, not 2, 1, not 2, 1. Why do I keep repeating myself like a crazy person? Because sometimes students mix them. Herpes simplex virus type 1, we call above the waist. That's the cold sore. Type 2 is the sexually transmitted infection, which we call below the waist. We'll talk about that one when we do STIs. Okay? They're superficial. They come whenever we're stressed, and they follow the same path. Okay, cause these nasty sores to our mouth. Very embarrassing. They're painful. If it's a severe one, then you may end up with the sore throat, the swollen lymph node, the drooling and everything. Get your Breva, get it early. And they have all these little vesicles. Okay, I point here because mine comes here all the time. And, research shows about 98%, I would say it was 98 last time I read it, of the population has herpes simplex virus 1, right? And it follows the same track. I get mine during the holiday. I don't even know why, because I don't feel stressed during the holiday, but I handle stress differently. My sister, same thing. She gets hers right about the same area. And if you look without lipstick, you can see my little scar from my cold sore. So it could be any part of the mouth, but it comes in the same spot every time. You see here, after you become infected, the virus stays in your body and may cause cold sores to return throughout your entire life. It becomes dormant when you don't see it. So remember that word. It becomes dormant when it's not, visible. And sometimes I feel the itching there, and I'll already put my Abreva. That little Abreva tube, I'm not even exaggerating. I wish I had time to run and grab it to show you. It's about that big, and it's like $17. Extremely expensive for such a small amount of medication. The first time you get it, it's the most severe. I've seen that in text question. I think Kaplan throws it at you. The first time you see it, so pay attention, right, to time. Whenever you see time in your question, that test taking strategy. It's most severe. Like the first time I had my cold sore, I can tell you when. Somebody was a baby. Might have been Michael. That's how long ago. I thought I was having an allergic reaction. That's how severe it was. Literally, my face grew. I was like, oh my God, what's going on? It was just because my first time having it. I literally went to the urgent care. That's how bad this was. I'm like, oh my God. So the first time is most severe, and then after that, it's usually not a big deal. Okay, as a matter of fact, the moment I see it, I pop it, I get all the fluid out of it, and I'm very aggressive and severe with it and get it out. So sometimes I'll get it and you won't even know because I handle it right away. But it spreads, right? Direct contact. So no more smooching during those periods, right? No kissing, no sharing of the utensils, cups, and all of that. My youngest son gets them frequently as well, Daniel. So every now and then I see them on him and I'll tell him, yeah, don't share cups with your siblings because I see his coming. And a lot of time I see them on him, he doesn't even notice, okay? But if it's a child who it's aggravating them, because normally it itches, but for him, I don't see him do that. He's not the typical book. So generally the book tells you it itches, so they're touching it and stuff. So make sure they wash their hands frequently and they're not sharing. But my other children don't seem to get the cold sore. Just me and Daniel are the two that gets it frequently. When that fluid field, that's all NCLEX stuff, you know, they're contagious, exclude them, no spoons, forks, and like don't share stuff, okay? Keep them from anybody who's immunosuppressed. If you have a newborn baby there, if you have other children with open wounds, all of that makes sense, right? And of course, no smooching. It's so crazy. I remember him having it one time and he was just all over his father. I'm like, oh, you're done for. But he didn't get it. All right, so you're good with the cold sore. Croup is our next one. Actually, I don't have, let me put my thing here so I can see with your questions just to make sure. Because I had to charge this. Okay, so I think everybody's good. If you had a question I missed, put it back so that way I don't need to change screen to see your question, okay? All right, this one is an important one, croup. Croup is an infection of the throat and vocal cords, right? And the reason why croup is so important because croup sometimes can cause laryngospasm, right? Which causes the airway to shut down. So that's what makes this disorder super important. Okay, so croup, it is caused by a virus that causes the lining of the throat and the larynx, that laryngitis that it causes it to become red and inflamed and swollen. Okay, very dangerous. So when children are under 5 years of age and they have that illness, it's called croup. And remember, they sound like a seal, right? They're the ones who sound like that animal, like a seal. Laryngitis is dangerous. Okay, this is the child where we tell you don't have them open their mouth and say "ah," because when they do, then you causes the larynx to literally shut down all the way. So at first it was swollen, you know, a little bit of air going through, but when it shuts down all the way, no air is going through. Okay, it can start days after a cold and causes by that same virus and cause, you know, the common cold symptoms. Okay, so it's gonna seem like they have a cold, but they're gonna sound very hoarse. They're gonna sound like a barking, you know, animal. I can't do it, but like the sound is in my head. When they breathe, it sounds like that one sounds over like it should sound like. And like sometimes they'll use their excess muscle. You'll lift up their shirt, their clavicle is sinking in, their intercostal cages are sinking in, they're exhausted. And sometimes they'll present to the ER with what we call the 4 Ds. They're drooling, they're dyspneic, they're gasping for air at times. So sometimes this could lead to a medical emergency, okay? But how is it spread? Direct and indirect, okay? If they're having secretion, they're touching their faces and they go touch another child. The hands again, wash your hands frequently. If they're coughing and sneezing, somebody walks in and breathes that. So that alone tells you how to prevent from catching it, okay? If it's mild, not a problem, they're not coughing and sneezing stuff, but if they are, isolate them, okay? Anytime there's coughing and sneezing, they need to be by themselves. So home remedies, you can do the warm mist, okay? If it's cold outside, cover them up. Keep them calm. But if it's severe, they may need to be hospitalized, okay? But hand washing with this one. Okay, cryptosporidiosis. Okay, crypto. Okay, for short. Cryptosporidium, tiny parasites. They live in your gut. Okay, us in animals. You know how we have these normal floras. So similar, these are not good guys though, but we have these normal floras in our gut. They don't hurt us, but these are nasty. With these, you're going to have some GI issues, obviously, right? And whenever there's nausea and vomiting, we're thinking electrolytes and fluid, but not too big of a deal. Hand washing, another one, you know, dirty food, dirty water, dirty hands. It's oral fecal. It's oral fecal. Okay. So if we prevent from eating uncooked stuff and drink clean water, you can avoid this one. This one is not as common, which is great. So don't worry too much about it. Now this one is important. E. coli. E. coli is an important one. Diarrheal, so it has another name, diarrhea, illness, and hemolytic uremic syndrome. Okay. The E short for Escherichia coli. There are different types of them. Okay. So for the most part, they're harmless, but some cause some nasty symptoms. Loose and watery diarrhea that gets bloody. And that's the key word you need to remember for NCLEX. So the moment you see bloody diarrhea, please think E. coli. That question has been floating on the NCLEX for a very long time. Bloody diarrhea, E. coli. Okay, with the stomach issues and everything, fever. As far as recovery, not long, there's not much you need to do. The other thing you need to worry about this one is sometimes if the child is super young, then they might end up with the hemolytic uremic syndrome part. Okay, that deals with the kidneys, okay, which we are always concerned about. So they may need hemodialysis temporarily. So they may need to be hospitalized if that happens, if it affects their kidneys, okay, because if ignored, it could cause kidney failure. Okay, they also end up with low platelets, okay, which is dangerous. So they get anemic, hence the name. Okay. But if you catch this early, not a big deal. Okay, nasty symptoms, but not a big deal. Don't let it get to the point where we're talking renal. Again, cook your food, wash your hands, don't drink dirty water. Oh, it's like, oh, right. Fifth disease. So this is another one that the child is contagious and nobody knows for a while. It's viral. Okay, this is sometimes called slap cheek. So these are the ones where the children looks like you hit them in the face and they're all red. Here looks like you slapped them on the face, literally. I think all the children have had fifth disease. Yeah, and I think it started with Kayla, who came home with it and then gave it to Gabriel, who gave it to Daniel, who was a baby at the time, and even Michael, who was like in his early teens at the time, ended up with this. Okay, not a big deal. Wears up on its own. They get this little pinpoint rashes, nothing major, viral. They get them. They didn't even get these flu-like symptoms, but you could have the runny nose and all of that stuff. It wears up on its own because it's viral. There's nothing to do. Keep them hydrated, comfortable, nothing special. But the problem is you don't even know they've been exposed to it until like one of the first signs would be the rash. But they've been contagious. Okay. For like a good week before that rash shows up. That's the nasty part about this. So fifth disease, erythema infectiosum, that's the one with the slap cheek disease. Sometimes you'll see the term because it makes their cheeks red like you hit them in their faces. Okay. So it's spread through direct and indirect. So same thing again, wash your hands, stay away from other people, but it doesn't kill. Gardiasis, beaver fever, not as common as this used to be. So this one is not a big deal, especially if you're not around animals, you're not likely to get this. okay, caused by bowel infection. One person or animal is infected with Giardia. So it's mostly people who owns a bunch of cats and dogs and cattle, especially if those are outside animals. They eat other dead animals. But if that's not you, then most likely you're not going to get this. So again, direct, indirect contact, dirty food, dirty water. They clean the cat feces, the dog feces, and they don't properly. And that's how you, or fecal, eat. Hemophilus influenza type B. Okay, so hip was the most common cause of bacterial meningitis until, we started vaccinating stuff. In children 2 months to 5 years, we're so on top of this now. These days, you don't see this much anymore. Okay, it has decreased significantly. Thank God. You see this maybe in third world countries, not here. Signs of fever, vomiting, tiredness, bulging fontanelle, if their fontanelles are still open. The stiff neck, mucorigidity, right? So the bacteria can cause epiglottitis, we just talked about earlier. That's very dangerous. You swallow, your epiglottis is supposed to cover your trachea every time you swallow. Imagine it inflamed. Bacteremia, septic arthritis. So you see all the madness this could cause. Thank God we've kind of mostly eradicated this. Okay, through contact with secretion from nose and mouth. Again, stay away. Breathing in air contaminated with bacteria after an infected person has cough or sneeze. So anybody who's coughing and sneeze, isolate them. That tells you you're gonna have on your face shield your mask. No kissing, no sharing. They're contagious as long as they're coughing and sneezing. Now, here's an NCLEX question right here. This is so important. So with the bacterial infectious disorders, the moment you put the client on antibiotic, you need to note the time. Because once they're on the antibiotics for 24 hours, so it's about 24 hours, they're no longer contagious. So you can isolate this person, right? So client comes in, here's the NCLEX question. Client comes in and the physician diagnosed them with Haemophilus influenza type B, right? And once it's found to be from bacterial, you want to isolate them, okay? So cause of bacterial meningitis, you want to isolate them, right? Let's say you start the antibiotic 9 p.m. So by 9 p.m. the next day, they're no longer contagious, okay? You can go ahead and take them off, okay? So this is a great question that's not going to go anywhere. Exclude child from school or child care until 24 hours starting antibiotics, okay? Here's another NCLEX question from here. Okay, so we talk about it not being as common as it used to be. Okay, we call tetanus signs and symptoms. I think sometimes the name throws students off. Okay, so don't let the name throw you off. It's commonly caused by bacterial. I know what's causing my mind. So there's a commercial going on right now because we're almost back to school, right? So right before school, you'll see these commercials and they're gearing them towards freshmen in college because of the exposure. So you want to make sure your young adults are vaccinated before they go to college. Very prone in the dorm rooms with this one. Okay, that's what's crossing my mind. Okay, hand, foot, and mouth disease. My youngest had this, and it's so funny. When he had this, his cousin came to visit, and they couldn't play together. They were very confused, y'all. Imagine 2 4-year-olds not allowed to play together. Literally, they're watching each other across the room because we're isolating one from the other. And I have some nasty pictures of what this caused my son, like all inside his mouth. He had the sores, he had it under his feet. And he was just a typical book with the hand, foot, and mouth disease. So hand, foot, and mouth disease is caused by Coxsackie virus. I don't even know where he got it from. Yeah, he was going to 4K at the time. And it was the summertime. And he was 4 years old. So see, I'm telling you, he was a typical book. So hands, foot, and mouth. Sure enough, I need to add his picture to these teachings. Literally, he had like all in his mouth. His face is started under his nose. It was all crusty and just like the book. So fever, sore throat, headache. The painful blisters were on his tongue and gums. Okay, they were on the palm of his hands, fingers, and toes. Yes, so typical. Okay, direct and indirect contact with the nose, mouth secretion. I'm sure he got it in school. It is what it is. Breathing in air contaminated if they're coughing, sneezing, okay, touching and then touching each other. That's why we had to isolate them. They literally could not play together. It was such a horrible time for a visit. So now when they got to see each other later, they were so proud, but they just didn't get it. It was just, we were watching them watching each other, not being able to play together. Child can attend school or child daycare if the child feels well enough to take part in activities, but once those blisters and everything have all healed, right? And they're contagious way before this even starts. Okay, so yeah, isolate them, wash all their stuff separately. Head lice, we mentioned earlier, a couple of things I want to pull from head lice. So the whole comb and sharing and everything. Yes, we talked about that already. But here's an NCLEX question right here, the eggs. Now, when you're treating this, you need to make sure you kill the eggs. Because if you don't kill the eggs, what have you done? Those eggs are going to lay babies, right? Whitish, gray, tin, yellow ovals. And we're not talking a little babies. These lay thousands of babies, okay? So let's go to treatment with these. You know they're going to be itchy and all of that. And you know it's from direct. You touch one child's hair and touch the other child's hair, or you use the same comb for the other child. So you want to boil their things. Okay, you want to keep their stuff separate. Where is your treatment? Right here. Okay, we talked about the spread. There's a section where it tells you to make sure you kill the eggs. That's the part I'm looking for. So make sure you kill the eggs, because if you don't kill the eggs, then you didn't do anything, okay? You know about the sharing. With hepatitis, so now you know there's hepatitis A, B, C, D, E, F, right? I know. We'll cover hepatitis in details when we do gastrointestinal is where they're covered because they affect the liver. Okay, so that's why we cover it under that umbrella, because but here is the infectious part we're going to cover because we're under infection control. Okay, because it affects the liver, you know, jaundice is going to be part of the signs and symptoms in addition to the fever, fatigue, all of that. So with these conditions, all of them, whether it's A, B, C, D, E, F, they all affect the liver. Okay. So now Hep A is oral fecal, right? Dirty food, dirty water, okay? So if you wash your hands or you eat food that's cooked, right? You can avoid this. You'll never catch it because that's how you catch it. But there's no, you have to let it run its course, right? There's no, you want to prevent it from killing the liver, causing cirrhosis of the liver or hepatic cirrhosis. But other than that, it's not a bacteria, so there's no antibiotics. Okay. Okay, this one is so important. Hang in there for me. What time? Okay, I have time. Impetigo, depends on your accent. This one is extremely important. Common skin infection that is caused by strep, okay, or staph, nasty little bugs, Streptococcus aureus and Staphylococcus aureus. They're bacterial, so you know we're gonna use antibiotics, yes, but these are contagious, okay? Not only are they contagious, they also affect the kidneys. So we wanna be very careful and aggressive with treating these, okay? They start with strep and staph. That's why when you come, you know, with a strep or staph infection, we follow you with renal issues because that is a common cause of pyelonephritis. So you'll see this sometimes too, scalded skin syndrome. So NCLEX question, you will see these terminologies, so be very familiar with them. So these are the children with the clusters of red bumps or blisters that are red. And sometimes you'll see the words honey right here. I knew it. Honey colored yellow. They use these terminologies. So be familiar with them, okay? I have a PowerPoint on Riggs NCLEX for you called Semiology or Skin. You'll see a beautiful picture I have, those of you who are visual learners, so you can see that yellow honey colored crust, right? So you'll remember that with impetigo, okay? Direct contact, so keep them away from each other. This child should have their own utensils, everything. Don't share anything, very, very contagious. And if they have any type of pruritus, keep their nails short because they take it from one area to the other, okay? Exclude them until 24 hours on the antibiotic. So whenever you see bacteria, that's the rule, okay? Wash all of their stuff. Whatever can be thrown away, throw it away, okay? If you're going to keep it, it needs to be washed in hot water, okay? NCLEX right here, okay? See, that's my job, to pull out the NCLEX stuff. You're very familiar with, general influenza. At one point in time, you might have caught the flu, so you're good with that one. I don't think we need to go over that one. Measles, let's go over this one, okay? Most contagious communicable disease caused by measles virus and is leading cause of vaccine preventable death in children, thank God. They're gonna have fever, cough, runny nose, okay, small red spots, dusky red blotchy rash. This could be diagnosed early with blood work, okay? And look how you catch it, through the air by droplets. So negative pressured room, okay? Negative pressured room for this one. Can survive in small droplets in the air for several hours. So the person coughs and sneezes in the mall and they go about their business, and here the rest of us come and take deep breaths. Terrible. I have to exaggerate for you to get it, but although that's not really an exaggeration, people have done that. But thank God for vaccines. Okay, they're not going to school, and they're not going to school until 4 days after the rash appear. Exclude them. No daycare, nothing. Stay away from your family. You're contagious, very contagious. People that haven't been vaccinated, very dangerous for them. Okay. Okay. Give me a moment. I'm going to check on you in a second. Meningitis. Inflammation of the meninges that surround the brain and the spinal cord. It could be viral or bacterial. So this one is special. But the most important one, not most important, but the one you want to pay attention to is the bacterial. Why? Because they're contagious. Okay, bacteria that can cause meningitis, Haemophilus influenza type B, we just went over earlier. Okay, Neisseria meningitis, streptococcal, group B streptococcal. We're going to talk about meningitis when we cover neuro, but this is the infectious part, okay, with the little ones. Earlier I mentioned your college student, your dorms. So you want to make sure, that they're educated, vaccinated, Okay, they get that nuchal rigidity we talked about earlier. Direct contact, so you know what to do. I sound like a broken record, right? Hand washing, stay away from each other. Okay. So meningococcal meningitis. Okay, so you know you're isolating that child until 24 hours of them being on the antibiotic. I sound like a broken record, right? No more sharing anything. You're by yourself. Okay. MRSA, special one, methicillin-resistant Staphylococcus aureus. So MRSA bacterial, and it's bacterial that is resistant to this antibiotic, methicillin. Can you imagine? Have become resistant to methicillin, penicillin, amoxicillin. So this is spread via contact. Staph infection of MRSA may include red, painful bumps under the skin. These sores are very painful. Skin to skin, especially when it ends up in their wounds. So definitely don't touch that patient without protection. Okay? That you need to cover that area if it's open. Okay? And click, that makes sense. And they're not sharing anything. You figured that. This one is not, you don't see questions on molluscum anymore, which is great. Mono, yes. Mononucleosis. Caused by Epstein-Barr virus. I mentioned mono earlier with that other table that I told you you're going to spend a moment with. Okay, common in older children and adolescents. Okay. Fever, sore throat, swollen lymph. Okay, very painful for them. Lethargic. They always feel exhausted. Their liver and their spleen gets large. They end up with jaundice. He's talking liver. Makes sense. Spread through direct and indirect contact, nose, mouth. So isolate them. No kissing anybody. No sharing all those lovely utensils. They're infectious. Isolate them. So this is the child where no more contact sports for them. Why? Because of all this lovely stuff we mentioned earlier with the enlarged spleen and liver. The NCLEX question with mono deals with dodgeball. No more dodgeball. No more football. No more anything, right, where they're going to come in contact, because you're going to cause more damage with the spleen and the liver. So if it's a young teenager who loves to play football, that's a problem. Okay. Mumps, by mumps virus, we don't see this much anymore. Again, because of measles, mumps, rubella, right? We vaccinate. So they end up with the swollen glands with mumps. Direct, indirect. You don't see Norwalk anymore. Pertussis, or also known as whooping cough. Very contagious. Respiratory. Bacteria respiratory. So you know you're isolating. They're going to have all these lovely runny nose, coughing. Hence the name. Okay, so same thing. Lock them up. That sounds terrible. But you get it. They can't be sharing stuff with everybody and spreading their wealth. No. Pink eye, you're familiar with. Don't forget, when you're caring for pink eye, you need to use disposable, right? Whatever you're using to wipe that crust and that exudate needs to be in the garbage. Okay, very contagious pink eye. I don't even have to come near people with pink eye to get pink eye. I hate it when I was in the ER, somebody coming with pink eye, because I knew I was going to end up with it. Okay, very, very contagious. There's infection control questions with this one, with the, pleasing. It's because they get a lot of exudate and crust. You need to know how to handle that, right? And their medication, if they're prescribing the ointments and drops, knowing how to instill them. We'll do that when we do intro to farm. Touching the discharge from the infected and then to another. Don't ever let the tip of the medication touch the conjunctiva. And this is also one of those things that need to be properly diagnosed. Okay, my youngest son, if I have time to tell you this story, he was misdiagnosed, and we thank God he's okay, but that could have gone the wrong way if I wasn't proactive. Okay. Pink eye is caused by bacteria, and the child is started on antibiotic treatment. He or she may not be contagious for 24 hours after starting the antibiotic, but you still want to do, infection control measures with when you're cleansing and cleaning. Okay, like the applicators and stuff you use to put the medication, they have to go in the garbage. Like, don't reuse those things. Okay, so but once they're into antibiotic, they can return after 24 hours. Okay. Pinworm we mentioned earlier, tiny white, they live in the intestine. So not a big deal with those. When children eat a lot of sweet stuff, they may end up with that. Okay, they get that itchy butt, right? And they don't know why. That one's a lot of fun. You can suffocate them with Vaseline, but their eggs can live up to 2 weeks outside of the body. That's why you need to make sure, you're washing everything with hot water and clean all their toys, because that's a long time. You can pick it up and pass it around and, yeah. Yeah, gross. Okay, eggs, kill the eggs. Anything that's making eggs, kill the eggs. RSVs on your NCLEX. So RSV, the ones that are prone to it are really young children, 1 to 2 years old. What happens is they catch it from us, the adults, breathing on them. It doesn't make us sick, okay? RSV is a virus that causes upper and lower respiratory problems. It can cause bronchiolitis. It's usually mild, not an issue, but if the child is immunosuppressed or they're a premature child, then they could end up in intensive care and end up on a ventilator. So we do take this serious. The younger they are, the more serious, because what happens is they end up with acute respiratory syndrome. Yeah, they could end up on a ventilator. So not a nice one. And they, again, catch it from us. So we can get vaccinated from it. And you could also don't speak over the child. Don't lean over the child. It's in our nares, right? So when you're coughing, talking, breathing over them, you end up infecting them. Okay? Through contact with infected secretion from the eyes, nose, and mouth. So that's why you don't have strangers breathe and talk over your newborn baby. Right? That makes sense. Because that's how they catch it. Okay? Okay, ringworm, similar to the other one. Rhodiola, yeah, rhodiola you still need to know about. Viral. With rhodiola, fever, swelling of the eyelids. I'm trying to think if there's how prominent this one still is, just in case. The little ones again with this one, we're talking 2 years and younger. Okay, again, the nose, the mouth, all of that. So you isolate to decrease the spread of. The other thing you need to keep in mind as we go through these, who's back, which is bacteria, which is viral, because we're going to talk about roommating. We're going to practice roommating questions, and that's where this stuff comes in. Okay, rotavirus, most common cause of severe diarrhea among young children. Okay, 2 years and younger again. Fever, vomiting, diarrhea, obviously. They have the virus in the stool. So oral fecal, wash your hands. Anytime you hear me say diarrhea, because you go to the bathroom, they don't wash their hands. So you teach them the hand washing to prevent the spread of. Okay. Rubella. Rubella is another important one. Viral. That's the German measles one. Okay. Once, and then by the way, these things, once you have them, you have immunity for life. Okay, this isn't passive immunity where when we give you the vaccine, that's passive immunity. I'm going to go over that in a moment. Passive immunity wears off. Passive immunity is from the breast milk or the placenta. But when you have chickenpox, when you've had measles, mumps, rubella, you have immunity forever. Okay, an infection with the rubella virus gives lifelong immunity. This is never gonna wear off. You're gonna die like that. Okay. Okay. Usually a mild disease in children and adults, but it can cause some confusion. You get a low-grade fever, malaise, they get tired, they get a nice lovely rash. If the woman is pregnant, we're worried. Remember, whenever a woman is pregnant, we keep them away from any childhood. Like if they come in contact with a child with rubella, a pregnant woman comes in contact with a child with rubella, I'm worried. I'm making sure that she didn't contract this because it's very dangerous in pregnancy. It could cause miscarriage and stillbirth in the mother. You could lose that baby. Okay, so pregnant women ought to stay away from anybody you know who haven't been vaccinated or could catch it. Okay, nose and throat secretion, air. Okay, salmonellosis, bacteria. So here, the bacteria infects the intestine of the person and animal. So they're gonna have some diarrhea. This falls also under the oral fecal. Clean food, clean water, wash your hands, umbrella. Okay, you see so many disorders here from dirty food and dirty water, right? So cook your meat. Scabies, you can group. This one. Shigella, I'm trying to think. Have I seen? Yeah, I've seen some Shigella questions. Okay, bacteria. I have a document for you that puts them all in their category, so don't worry. This is the in-depth stuff, right? So this one's bacterial, found in stool, so you know you're gonna hand wash. Okay, so you can well, the categorization has already been done for you. We talked about shingles. So as you can see, that's a lot. So this one, do you see how it's already been grouped for you? Right? So contact, we went over RSV, scabies, Staphylococcus aureus, and impetigo, group A, like that, right? You get the point. Standard, some of this we haven't covered because they just fall under some specific areas, and we'll go over all of the hepatitises. It's not really a word. Those fall under standard. Your droplets, we went over influenza, we went over pertussis, we went over diphtheria. Your airborne, we went over chickenpox. So you get the point. So you need to spend time over this document as well. I have to cover them with you. Okay, so level of disaster. There's different levels of disaster. Level 1, 2, or 3, right? Level 1, we're talking like state impacted, federally impacted, 9/11 type of madness, okay? Level 2 is more regional and confines up to like your county, which is still requires major effort, right? Level 3 involves minor or average level of damage, like locally, right? Your city type of disaster, okay? Now, emergency preparedness and response, you have to learn how to triage. The way you triage and be able to tell who do you see first, second, third, right? Is you need to outline who's non-urgent, who's urgent, and who's emergent, right? Your non-urgent and urgent is non-life-threatening. It's important, but it's not going to kill you. That's another way you can define that. Emergent is life-threatening. If I don't do something, you will die. But now this gets complicated just a tiny bit. There is a spectrum. You know me and my spectrum. So imagine a spectrum, right? A nice stick. There's a spectrum, and there's two ends to a spectrum. Everything has a spectrum. There's a beginning and an end. There's a start and a finish, right? So imagine a spectrum. On your spectrum, there are these clients who are non-urgent. It's not a big deal. Nobody, I don't want to say nobody cares, but if I ignore you forever, you'll live. Okay? And then you have your non-life-threatening, somewhere in the middle there. You have your life-threatening, I could do something and save you. And then you have your clients on the end of that spectrum who, no matter what you do, will die. You got to keep the whole spectrum in mind, because this is where you need to be able to tell, who do you waste your time with? Waste is not a good word. Who do you invest your time with? Right? You invest your time with the life-threatening, emergent people. Why? Thank you for asking why. Because you're talking mass emergencies. Who can you help to have you help others, right? Who can I save and they save somebody else? Because our goal is to save as many people as possible. Who in the ER, that walks in the ER, that I invest my time with? Not everybody. I remember watching an untold story of the ER where she had a client sitting in the waiting room who was having, she was obviously mentally unstable. There were these two other clients that came in having gotten bitten by bees. And then while she was dealing with them, these guys came into the ER and threw another person in the, literally threw a person in the ER who had been shot and stabbed in the eye, right? With all of these people, you have to decide, who do you see first? So this is what we're talking about here, okay? So specific hazards with associated with certain diseases. Again, we're talking emergency preparedness, mass casualties. So some of these are associated with bacterial and some of them are viral. We're still under that same umbrella as earlier. Anthrax is bacterial. So the drug of choice to treat anthrax is Cipro. Now, anthrax is caught in certain ways. So let me go there and I'm going to come back, I promise. So anthrax could be cutaneous, gastrointestinal, or inhaled. Pay attention in that question. How did they catch it? Is it on their skin? Did they swallow it, or did they breathe it in? Because if it's on their skin, person to person, not too big of a deal. Even ingesting it, swallowing it, they're going to have some nasty stomach ache, diarrhea, but they'll live. Well, if you don't treat it, they might not. But if you treat it, they'll live. 50% chance. But inhaled, they'll die within 46 days. So pay attention how they caught it. Plague is bacterial, okay? Found on rodents and fleas. We just talked about vectors. That is destroyable with sunlight. Open, that's why sometimes it's good to just vent stuff. Vent it, open the doors and windows when it's hottest outside. Turn up your AC and kill some stuff, right? Treat with streptomycin, gentamicin, doxycycline, Cipro, that whole family. Smallpox is viral, just like chickenpox is viral. And similar to chickenpox, they cause these high fever, rash, red spots that must be dried up, crossed off, fall off, or else you're contagious. Same thing, right? With chickenpox that we just said. Viral hemorrhagic fever, the name tells you so much. It's viral, there's some bleeding, there's high fever, right? Okay, so you need to be familiar with these, which ones are viral, which ones are bacterial. Okay, they're still working on an anthrax vaccine. I don't know if it's ready or not. A nurse assists in writing a community plan for responding to bioterrorism threat or attack. When reviewing the plan, the director of the emergency operations should have the nurse correct which intervention. All personnel should wear protective clothing, including a gown, gloves, and respiratory protection. A client exposed to anthrax should immediately remove contaminated clothing and place it in the hamper. Client should be instructed to wash thoroughly with soap and water. Access to the area should be restricted. So go back to your question. The word correct, you should have processed. have the nurse correct. So that tells you you're looking for something wrong. Now, if you don't do that, I don't know how you're going to get to the correct answer. You have to remember these test taking strategies. So if you did this question and you went to the answers but didn't check out this one word, go back. Because for me, I don't know what's happening to you when you don't pick up on keywords like that. I'm lost. Like, you'll see me practice a question with you out loud and I'll go back and be like, what am I looking for? Okay? Should have the nurse correct with intervention. So something here is wrong. Throw me some answers, please. Which one here is incorrect? Where your supervisor or the director, the director of the emergency operation would say, this is bad from your what are they writing? A community plan. Talk to me so I can show you, see what's going on in your mind. But you see the test taking strategy here. Have the nurse correct. So I'm looking for something wrong here. All personnel should wear PPEs. Great. Wash thoroughly with soap and water. Great. Restrict access to bioterrorist records. Yes. The problem is number 2. Expose those who've been exposed with anthrax, remove their contaminated clothing and put it in a hamper, like the same hamper that I'm going to be using. That's what's wrong with that one. Yes. So I see most of you got that. Beautiful. And I see you're awake also, which makes me very happy. Here's a picture of smallpox. Okay. Now, these will cause severe acute respiratory syndrome. Okay, they go down to the alveoli and collapse it. I'm going to show you a picture of that. Okay. With acute respiratory syndrome, it is respiratory illness which brings about atypical pneumonia and infected clients. So the alveoli, the air sac in the lungs, swells up and collapses. That is where you exchange air. With a collapsed alveoli, how do you exchange air? You can't. And that's what's wrong with these bioterrorist attacks. These items that folks are breathing in go to the alveoli and it collapses it, and that's how it kills them in 3 to 4 days. That's really the problem with the coronavirus too. It causes a lot of excess fluid in the alveoli. And with all that excess fluid in the alveoli cannot open and close and exchange. So they end up having to be on a ventilator. Okay? So that's the important part. The alveoli gets affected. I think there's a question here. A client with suspected severe acute respiratory syndrome comes to the emergency department. Which physician order should the nurse implement first? So they're coming in with SARS. Institute isolation precaution. You see the word first. You process that, right? Yes, you did. Bring in an IV infusion of D5. Obtain a nasopharyngeal specimen. Obtain a sputum specimen. What's the first thing you want to do when a client comes in with SARS to the emergency room? You want to isolate them. Okay? Go back. Where's my contagious word? Somewhere here. They're contagious. Isolate them. I think it's in the other PowerPoint. All right. So here, droplet precaution. We don't want that spreading. Here are some other biological toxins you need to be familiar with. Mustard gas, ricin, sarin, strychnine. Okay, be familiar with them. The moment you see them in a question, they are biological toxins and there is no antidote for them. These clients usually will die. All we're going to do is comfort measures. Okay, we're going to do the IV fluid. We're going to give the filgrastim, the PEG filgrastim, Neulasta, Neupogen to help them make white blood cells to fight back. But usually, right, they end up on a ventilator. Okay, they end up with an endotracheal tube, non-rebreathing mask, high flow oxygen. Okay, they end up with pneumo and hemothorax. And we're doing comfort measures. We're going to give the IV fluid, right? We're going to try and get their kidneys to not fail. We're going to treat the acidosis that's coming. We're going to treat the hyperkalemia. You know, since I said acidosis, they're going to be hyperkalemia. We're going to treat the hypocalcemia. So they're going to be an hypertonic solution that has calcium, okay, but no potassium because they're already hyperkalemic. So they're going to be on calcium gluconate 10% or calcium chloride 10%, 5 mL IV over 2 minutes. We're going to give sodium bicarb to offset the hyperkalemia, IV push slowly always. We're going to give regular insulin. That will help. We're going to give K-exolate, PO or rectally, try and get rid of some of that potassium. But they usually end up dying. Okay. We're going to practice these questions, but before we do that, I want you to go over these when you get a chance. We're going to practice questions. If we have time, we will, but this is all your CPR stuff. If you just renewed your CPR card, this is fresh in your mind. Let me see the time. Okay, yeah, we may get a chance to go over that. But this is all the CPR stuff, okay, with nice, beautiful pictures. And this is the current up-to-date CPR stuff, right? You know we're not ABC anymore, we're CAD, but let's practice questions. Let me make sure you don't have any questions before we jump to questions. You're gonna see roommating questions. There's still a lot more I teach you while we practice questions, but it's time. I want to make sure you understand this. And let me bring this here so I can see your answers faster so we can practice as many questions as possible. All right, everybody, be ready. All right. After correctly positioning a client for a wound dressing change, the nurse sets up a sterile field, placing the wound supplies in the field. So here we go. You have a sterile field, your wound supplies are in the field. And it's sterile because there's a wound and we're going to touch bloodstream. You know that. The nurse hears a page to respond to another patient who has fallen in the hallway. Which of the following is the most appropriate nursing action for the nurse to take? So you position a client to change their dressing, you set up your sterile field, and then another one of your clients fell. What's the next thing you should do? Since I read the question to you, you only have 30 seconds. When I read them, 30 seconds. If I don't read them, then 60 seconds. Yes, yes, it is. So let's go over it. Ensure the client's safety. That's good stuff, right? So far, half of it is right. Cover the field with a sterile towel. Yes. If the word sterile wasn't there, that would be incorrect. Do you see how one word changes everything? So you have to pay attention to details. And then you respond to your other client. So your sterile field stays sterile. Your client is safe. You ensured their safety. So hold on to number one. Hold on to A. Nothing wrong with that. B, continue quickly. That one word, everyone, one word. Don't even read the rest. Because if half of it is wrong, the whole thing is wrong. C, ensure the client's safety. Yes. Awesome. Discard the sterile equipment. Now, that makes you a money waster. I don't want you working in my facility. I need to save all the money I can save, so at the end of the day, I get my Christmas bonus. Okay? Now, I know we're in August. Christmas is around the corner, believe it or not. By the time school starts, those Halloween stuff will be out. You know, once the Halloween stuff is out, Christmas is here. And then we're in 2022. This is so not Netflix. All right, but you get the point. Don't waste money. You are cost effective. We talked about that before. Do you see how, even though we're still at the beginning of the review and the process, you see how we're already building upon and building upon, because we talked about this already. You are cost effective. D, explain the situation to the patient needing wound dressing change. Leave the sterile field. You can't leave it. You leave it like that. Why? There's pathogens in the air. You can't just leave a sterile field like that. It's no longer sterile when you come back. So here's your answer. A patient falls. Okay, yeah, we know the question. D would lead to contamination. Where's the cost-effective one? It's somewhere here. Yeah, you're wasting supplies right there. Okay, so A is your best answer. Okay, let's try another one. The RN is making decision regarding client room assignment on a pediatric unit. Which possible roommate would be most appropriate for a 3-year-old child with minimal change nephrotic syndrome? Okay, great teaching opportunity here. When you're roommating, you always want to roommate clean with clean, dirty with dirty. And with dirty, we mean that respectfully. You know, I'm not a disrespectful person. You're not a disrespectful person. So the whole clean and dirty is for the sake of learning, okay? So by dirty, we mean anybody with a fever, anybody with itis, right? in their situation. Anybody with open wound, anybody who's coughing and sneezing and, right, spreading that mess. So those are all contagious, dirty, infectious, right? Clean, we mean immunosuppressed, chemo, radiation, low white count. Okay, you get the point. So those are clean people. So now, what you need to remember and understand, I'm looking at some of your answers. Okay. Is you have to ask yourself, is the nephrotic syndrome child clean or dirty? So based on your answer, that's a clean child. So we need to pick another clean child. All right. Infection. Ooh, chicken pox, infection. Now, you're between C and D. I don't think anybody said D. Okay. So the thing is, sometimes students will say the sickle cell anemia crisis, but what happens, they could have gone into crises because of an infection. So your cleanest baby here is the hernia baby, because that's not from an infection, okay? That's from, you know, the protrusion with the wall, the abdominal wall is an inguinal, right? In the groin, okay? The groin area, it protrudes, so it's not from an infection. The nurse must know that children with nephrotic syndrome are high risk for developing infection as a result of standard use of immunosuppressant. So this is a child whose immune system would be low, so they would be considered a clean child, okay? So, so the infectious children cannot be around this child, okay? So the sickle cell could be due to an infectious process, but the hernia we know for sure was not. So you guys are good. C, awesome. The pediatric nurse needs to rearrange room assignments of clients to accommodate 3 additional clients who will be admitted during the day. Which 2 of the following clients would be best for the nurse to place together in the same room, select all that apply. So who would we roommate together? Encephalitis, low white count, appendectomy, scarlet fever, chemo. The age doesn't matter, y'all. I don't care if they're an 8, 12, 11, 10, 9-year-old. And they're all around the same age group anyway, so it doesn't matter. So block all that out. It's the diagnosis you're looking at for these type of questions. Okay? So roommating, it doesn't matter the age, right? All right, encephalitis, itis, low white count, immunosuppressed. Appendectomy. Why do we remove appendixes? Not because they're clean. Usually because they have appendicitis is why we remove them. Otherwise, we don't bother your appendix. Scarlet fever, right? Fever. Chemo, immunosuppressed. So which two here are immunosuppressed? Which two here are clean? Talk to me. Who do you roommate together? Yes, 2 and 5. Thank you. The child with the low count, okay, they're immunosuppressed, they're clean. And the child receiving chemo is clean. They could be roommates. Okay, we talked about the appendix and then fever and itis. Woo. And you see here, read this rationale right here. The children with infections should be cohort. So should not be cohort because one is viral and one is bacterial. So all that stuff we did earlier, okay, encephalitis, viral, scarlet fever, bacterial. You would never put a virus and a bacteria together. Same virus with same virus. Same bacteria with the same bacteria. Okay? We're learning so much. All right, so here are the fun stuff, or the more fun stuff, because we've done some fun stuff. A client diagnosed with methicillin resistant Staphylococcus aureus, MRSA. What type of isolation is most appropriate for this client? Reverse isolation, airborne isolation, standard precaution, or contact? But do you see how the stuff we did earlier with the different charts and all of that, going over standard versus airborne versus positive versus negative, all of that is foundation to build and help you answer these questions. So this is a contact precaution because MRSA is caught via contact. Yes. Okay. So body substance isolation, you'll see contact, that's an old terminology there, involve the use of barrier protection. So contact precaution means the nurse is gonna have on their gloves, they're gonna have on their mask, they're gonna have on their gown or their protective eyewear as appropriate. Okay. Whenever you're going to deal with any type of body fluid or anything, so you need to know your mode of transmission in order to determine the type of isolation. Okay, so all that lovely stuff we spend all that time on, those are the type of things that's going to help you answer these questions. So we're putting it all together now. Okay, in addition to knowing the organism and how it's spread, you also need to pay attention. So, because I could add to this, you're going to do irrigate a wound. Okay, so a client diagnosed with MRSA with orders of wound irrigation. So you definitely need to add these goggles, right? And you're going to see some questions like that. So let's continue. The nurse has performed the initial assessment of 4 clients admitted with an acute episode of asthma. Which assessment finding would cause the nurse to call the provider immediately? Prolonged inspiration with each breath, expiratory wheezing that has suddenly absent in one lobe, expectoration of large amount of purulent mucus, appearance of the use of abdominal muscle for breathing. So this is a priority question. So you have to imagine these clients on a spectrum. Which one here is priority? Who can I do something for real quick and save their lives? Yes, the expiratory wheezing and absent in the lobe. So let's talk about these guys. So this one, you're listening to them, and all of a sudden, nothing. That lung collapsed. So that's your priority client. You're calling that they're going to need a chest tube. Okay. The other ones, acute asthma is characterized by expiratory wheezes caused by obstruction of the airway. Wheezing or high-pitched musical sound that's trying to go through a tight airway. So imagine this is supposed to be nice and beautifully open, the airway, right? And then with asthma, it's closing down, so air is trying to seep through that. So they sound like, like they're singing. So sudden cessation of that wheezing is an emergency. So now you go from a tight airway to a collapsed airway. So that's your emergency person. But just out of curiosity, who would you see next? So we know we would see the expiratory wheezing that is suddenly absent in a lobe. That's because it has collapsed. Who would you see next? Is it the prolonged inspiration with each breath? The expectoration of large amount of purulent mucus? Or the appearance of the use of abdominal muscle for breathing? Who's next? Yes, D. I would see D second. Awesome. A nurse is caring for 4 clients. Each of the 4 clients has a priority nursing diagnosis. Based on each client's nursing diagnosis, which client should the nurse assess first? So this is straight right off the bat. Who do you see first? Which clients do you see first? With those types of questions, you need to think who's stable and who's unstable. Actually, same thing with the other question. I'm going to go back. This question, you could go through that question and say who's stable and who's unstable. Okay? Prolonged inspiration with stable, unstable, stable, unstable. And then between the two, airway, breathing, circulation, actual versus potential. So this is what we're going to use here. Okay? So we're going to go through all 4 of these clients, and you're going to tell me who's stable and who's unstable. But since we're not face-to-face, I'm going to answer the questions that I'm asking you. Because by the time I wait for you to chime in, like all this time goes by. A nurse is caring for 4 clients. Each of the 4 clients has a priority nursing diagnosis. Based on the client's nursing diagnosis, which client should the nurse see first? Okay, so when you see questions like that, this is a who do you see first? 1, impaired communication related to the inability to process words in symbols. So is that a stable or unstable client? That's what you're asking yourself. 2, risk for injury related to muscle weakness on the left side, secondary to CVA. Stable or unstable? 3, impaired gas exchange related to fluid and the bronchial secondary to hypervolemia. Stable or unstable? Acute pain related to interruption of tissue integrity secondary to surgery. Stable or unstable. I see your answers, yes. So let's say you had more than one answer here that was unstable. You would need to do ABC. Literally ask yourself, is there an airway problem here? So you could even do this. So some of you may have chosen two answers because sometimes you're like, oh, they're stable and stable. I'm not sure. So if you have two answers that are left, you need to do ABC, airway, breathing, circulation. Literally, you need to ask yourself, who has an airway problem here? Who has a breathing problem? Who has a circulation problem? Remember, test taking strategies. So airway would be first. If there's no airway issue, breathing. If there's no breathing issue, circulation. And if you still have more than one answer left, that's when you would do actual versus potential. We take care of actual problems first, okay? So the client with fluid overload is a priority in this case. Client with airway impairment are the highest priority, and it makes sense. You don't have as much time. With impaired gas exchange, the client is not allowed to exchange carbon dioxide for oxygen, and they will die if you don't intervene with that. Okay? Yeah. Leaving the client for air hunger. Depending on the situation, the nurse must decide whether to address pain or risk of injury. If the client's pain level is high, the nurse should address this first. If the client with risk for injury is safe. Okay, if the client with the risk for injury is unsafe, the nurse should address that client first. So I could add a little bit more to those two answers to see, who you go with first. So airway, breathing, circulation, safety, and pain are the order in which causes you to prioritize. That's how we operate. Airway, breathing, circulation, safety, pain. And the pain, remember, pain is special. So with the pain, is it physical pain? Then that would take priority, right? Psychosocial pain, we don't address first. We just don't, because it's not going to kill the client. So the client with impaired communication, that's not going to kill them. Okay? And don't read into these. Don't make it worse. Well, they can't tell me that. Nope. That's not what that's not going to kill them. Okay? These are awesome questions. All right. Now, every now and then, students encounter this question in the real exam. So we keep drilling you and preparing you and testing you. Who do you see first? That is the majority of your, questions in this section. Who do you see first? Yes. But every now and then, you get asked, who do you see last? You do need to know that. So remember that spectrum I was talking about earlier, right? Imagine the spectrum. And I tell you, some clients, it's not a big deal. We don't care. Get out of my ER. And then there's clients, no matter what you do, they're going to die anyway. Yeah. So that's who you would see last, right? The no big deal or the will die, the flat line, the 98% body burn. Like they're just going to die. So why spend time trying to revive someone who's going to die no matter what you do? I know that sounds a little bit insensitive, but that's how you have to think on NCLEX, okay? So try this question. Yes, the 98% degree burn. Okay, that child will not live. Toddler with that much burn, severe deep abrasion, will not live. They have the least chance of survival. The others have more of a chance of survival. Okay. Who would you see first? Who would you see first? So now you go back to the whole, yes, airway, breathing, circulation, the cinch eyebrow, that's very close to the airway. So you want to address them first, making sure that they're not building any type of edema, put some oxygen on them type of thing. Okay, perfect. Then you can go ahead and see the lower leg fracture because that's circulation. And with the bulging fontanelle, every time they cry, you know, once you calm them down, that might stop. There's nothing wrong with this child that we can see. All right, great thinking.